Good morning, everyone. I'm Laura Lucas, Senior Manager of Provider Education for the Association of Community Cancer Centers, and I'm eager to introduce Dr. Renato Martins, our expert presenter for the second E-course of the Institute of Clinical Immuno-Oncology, also known as ICLIO series, who will discuss the role of immunotherapy in treatment of non-small cell lung cancer. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by IO, and includes other vital resources such as newsletters, papers, the ICLIO Scholars Program, and a national conference scheduled for October 2nd in Philadelphia. I hope you'll visit www.accc-iclio.org to browse all of our offerings. Our upcoming e-newsletter resources will focus on the role of immuno-oncology in treating lung cancer. For today's webinar, please feel free to submit questions for Dr. Martins by typing your questions in the box on your dashboard. Dr. Jake Ginto will pose questions to Dr. Martins, who will address questions at the end of the presentation. The webinar will be archived and available on the ICLIO website by the end of the week. And again, that's accc-iclio.org. Now for today's e-course, I'm pleased to introduce our presenter and ICLIO scholar, Dr. Renato Martins, who's the Medical Director of Outpatient General Oncology Hematology at Seattle Cancer Care Alliance and Medical Director of the Thoracic, Head, and Neck Oncology, as well as Professor at the University of Washington School of Medicine. Dr. Martins' primary clinical focus is on head and neck cancers, lung cancer, and clinical trial design. Dr. Martins has been recognized as a top doctor in Seattle Magazine's annually surveyed for the past 3 years. Additionally, Dr. Martins has authored numerous journal articles and has served as lead investigator on several clinical trials. We hope you'll all join us for the ICLIO National Conference this fall, where Dr. Martins will join the faculty presenters. Now, I'll send it over to Dr. Martins.
Thanks for the introduction, and I guess good morning for most of you. Hopefully you can hear me well. So let's go to the first slide so we can review the objectives. I guess that will work okay. Okay, so we are on the objectives slide, and by the end of this e-course, we should all be able to understand the current treatment algorithm for patients with non-small cell lung cancer, the evidence supporting targeting the PD-1, PDL1 axis in patients with non-small cell lung cancer, as well as understand the number of drugs that are in development targeting this pathway. And finally, have an idea of the clinical trials that are in development to better understand the role of these agents in the therapy of non-small cell lung cancer. So now on slide 3, which is just obviously a very general review of histology in non-small cell lung cancer. Non-small cell represents between 85 and 90% of all lung cancers. And it's divided in squamous cell carcinoma, approximately 25%, and this category of non-squamous, which represents about 75% of non-small cell lung cancer, and the vast majority of those patients have adenocarcinoma. The estimated new cases of lung cancer in the U.S. are slightly over 220,000, with approaching 160,000 deaths. And although the incidence for both men and women seem to be dropping slowly, the number of cases as the population increase is yet to drop. And as I'm sure you all know, lung cancer kills more than the next 4 cancer killers. So now move on to slide number 4. Again, a very general, broad view of the treatment of patients with non-small cell lung cancer whose tumors do not have what we call a driver mutation, with obviously the most common one and recognized ones being EGFR, ALK, and ROS1. So for those patients that have a non-squamous histology, the standard of care in first line is a doublet platinum-based therapy, plus minus the addition of bevacizumab. And in second line, nivolumab has gained recognition by the NCCN non-small cell lung cancer panel as an alternative for these patients. In squamous cell carcinoma, platinum-based therapy is also the standard of care. Obviously, pemetrexed, which is approved for non-squamous, is not approved for use in squamous, and the reasons for that are beyond the subject of this talk. But in squamous, in fact, nivolumab is FDA approved for the treatment of patients with squamous cell carcinoma. So now moving to slide number 5. As you all know, the knowledge and recognition of checkpoint inhibitors as a viable alternative to treat cancer has exploded over the last few years. This story really started with ipilimumab, which targets CTLA-4, and its approval in melanoma. The way I explain to patients, and certainly is illustrated by this cartoon, is that the connection between PDL1 in the cancer cell and the PD-1 in the lymphocytes send an inhibitory signal to the lymphocyte. And the rationale behind use of antibodies, both against PD-1 and PDL1, is to break that connection and then remove that inhibitory signal to the lymphocyte, which is now, quote unquote, able to react to the cancer cell. So now moving to slide number 6. This slide, and aside from the cases, these slides are prepared by the iClear group, brings perhaps the most controversial issue right now in the immunotherapy of non-small cell lung cancer, and that's the issue of a biomarker. You know, we in lung cancer have become accustomed to explain outstanding responses to treatment with the presence of a biomarker, as the case of activating EGFR mutations and ALK-ROS1 mutations as well. Here, there has been a search for the biomarker that predicts for the amazing responses we see in some patients receiving immunotherapy for non-small cell lung cancer. Certainly, the most studied biomarker has been the expression of PDL1 either in the cancer cells or the immune cells present in the tumor. However, I would say that that doesn't seem to be the biomarker. It may be a biomarker, and I'm glad to revisit that in the question and answer session and explain the rationale for my comments. So now moving to slide number 7. This slide shows the 2 trials which led to the approval of nivolumab for patients with squamous cell carcinoma. I actually want to start with Checkmate 063, which is the phase 2 trial. This is a very large phase 2 trial with 117 patients. The objective response rate was 15%, and in unselected patients, we've seen that the response rates for these agents in non-small cell lung cancer seem to consistently fall between 15 and 20%. The data from this trial was used mainly to provide safety data as a companion data to the randomized trial Checkmate 017. I think that perhaps now we should speak a little bit about toxicity, and I'm going to return to that during the case discussion. But most of the serious adverse events associated with these drugs have been in less than 10% range. However, when they do occur, they can be quite dramatic in its severity. Mainly the autoimmune reactions. So Checkmate 017 was a randomized phase 3 trial between nivolumab and docetaxel for patients with metastatic squamous cell carcinoma, which had received one prior line of therapy. And as you can see here, the reason that this data led to the approval of the drug even before this data had been presented or published, to my knowledge, was because the improvement in overall survival with nivolumab was quite impressive. The median overall survival with nivolumab was 9.2 months, while the median survival for docetaxel was 6 months. So now moving to slide number 8. This is data that was presented at ASCO this year, and it's the basis for the acceptance by the NCCN panel of nivolumab as an alternative in second-line therapy for patients with non-squamous, non-small cell lung cancer. This was a phase 3 trial, a large study with 482 patients that were randomized to receive nivolumab or docetaxel as a second-line therapy. The median overall survival for patients treated with nivolumab was 12.2 months, and this was compared with 9.4 months with docetaxel. Again, as I had said before, the overall response rate was 19% for nivolumab, while it was 12% for docetaxel. And a higher PDL1 expression correlated with a higher improved survival. When PDL1 expression was present in more than 1% of tumor cells, the overall survival seemed to be better, so there seems to be a correlation between expression. Importantly, nivolumab seemed to have a better adverse event profile when compared with docetaxel. Grade 3 and 4 adverse events were reported in 10% of patients treated with nivolumab, while they were present in 54% of patients treated with docetaxel. Although this was obviously not an equivalence trial, during the question and answer part of the ASCO presentation, it actually came up that even if nivolumab had not improved the survival, it certainly seemed to have, irrespective of the subgroup study, a comparable, and I'm purposely avoiding the word equivalent, but a comparable survival with docetaxel at the expense of much less toxicity. So we're going to move on to slide number 9, and we're going to talk about drugs that have not been approved for non-small cell lung cancer yet. I think that the jury is still very much out regarding which strategy is going to prevail. And in fact, that's one of the questions that was submitted by the audience. Between targeting the PD1 part of the axis or targeting the PDL1 part of the axis. And one can make a pretty strong theoretical case either way. So targeting the PD1, just like nivolumab, there is pembrolizumab, and that is, as you see, has been extensively studied in non-small cell lung cancer, and in fact has a New England Journal of Medicine publication already as well. There is a PDL3280A, which targets the PDL1, and finally MEDI 4736, which also targets the PDL1. So next, slide number 10. This is the data from Keynote 001. That's the trial that was published at the New England Journal of Medicine and had an update at ASCO this year as well. This was a phase 1 study as a monotherapy in patients with advanced non-small cell lung cancer. They had a collection of tissue and performed PDL1 expression, although this was not a criteria for entry in the trial. It was a very large study with 495 patients. And overall, regardless of PDL1 expression, the median progression-free survival was 3.7 months. The response rate was 19.4. Again, for unselected group of patients, there is this consistency of response between 15 and 20%. And the median overall survival was 12 months, again, to a very heavily pretreated population. They had different cutoffs and explored the results in them. In the cutoff of more than 50% expression of PDL1, the median progression-free survival was 6.3 months. The overall response rate was 45.2%, and the median overall survival had not been reached. And again, as observed all across these studies, the rates of severe toxicities were low. There are ongoing trials evaluating the role of pembrolizumab. Keynote 042 is a randomized phase 3 trial for patients that have not received any prior therapy and have tumors with PDL1 expression. They're being randomized between pembrolizumab or a platinum doublet chemotherapy with the primary endpoint of overall survival. And for patients that have EGFR or ALK mutations, they must obviously have been treated with the appropriate agents. Keynote 021 is a phase 1/2 trial that is looking at different combinations of pembrolizumab with chemotherapy or with immunotherapy, namely ipilimumab. In fact, we have this trial opened at our institution. This year at ASCO, we saw preliminary data from this trial regarding the combination of pembrolizumab and ipilimumab, which had 6 out of 11 patients responding. I tend not to like to put overall response rates when we're talking about such a small number of patients, because the 95% confidence interval of 6 out of 11 is very broad. So I think that one should be careful not to interpret this 55% number as some type of truth, at least not at this point. As you all know, the combination of PDL1 targeting with CTLA targeting in melanoma has been associated with a substantial increase in the response rate. But unfortunately, that seems to be at the expense of significant toxicity as well. This is very preliminary data, but the data that was presented at ASCO this year, the toxicity did not seem to be as dramatic as the toxicity seen in melanoma with this combination. So now moving to slide number 12, this is the Poplar study. For some reason, all studies of this agent, MPDL3280A, seem to have names of trees, I suppose. And this was a combination of this agent versus docetaxel. The most interesting results were for patients that had tumors that had some degree of PDL1 expression, either in the tumor or the immune cells. The data that you see in this table is restricted to those that had a 3+ expression by immunohistochemistry, which obviously represents a small number of the overall trial, which had close to 300 patients. So you're seeing data here on less than 50 of them, showing that this degree of expression is not certainly the majority of patients with non-small cell lung cancer. In any case, with this highest degree of expression, patients treated with docetaxel had a median overall survival of 11.1 months, progression-free survival of 3.9 months, and a response rate of 13%, while the response rate for the PDL1 antibody was 38%. The median progression-free survival was 9.7 months, and the median overall survival had not been reached. So looking at the data and looking at the data on the 2+ expressors as well, one seems to come up with the clear impression that the more PDL1 expression, the better the results. So for example, on the 2+, the response rate was 22%. So we're going to move to the next slide, number 13, looking at the other ongoing trials with this same agent. So FIR, that's actually a trial that we had here at our institution, was a monotherapy trial in patients that had tumors that had any degree of PDL1 expression. I'm not aware of any results of this trial yet. I would say that any degree of expression in our institution was probably in the 50% range. And then the OAK trial is a randomized phase 3 large study, again randomizing this PDL1 antibody versus docetaxel. So moving on to slide number 14, we're going to now review the data with MEDI4736, which is the one that has the least amount of published data, or presented data, I should say. This is a phase 1/2 trial of this agent in patients with solid tumors with a non-small cell lung cancer cohort. And this is, again, a heavily pretreated population with a median of 2.5 prior treatments, and 149 patients with non-small cell evaluable for response. Again, not restricted by PDL1 expression, the overall response rate was 14%, again in that 15 to 20% range that we discussed before. If there was any degree of PDL1 expression, the response rate was 23%. Patients with squamous histology had a response rate of 21%, and non-squamous histology, a response rate of 10%. Again, with very similar safety data as compared with other agents. Now moving on to slide number 15. This is a summary of the ongoing trials with this agent. There is a phase 3 study called Arctic that is estimated to enroll 900 patients. This will be a study for patients that have received at least 2 prior lines of therapy, and they will be randomized to receive standard of care versus either MEDI 4736 by itself or MEDI 4736 with tremelimumab, which is a CTLA-4 antibody, if the tumor is PDL1 negative, with the primary objective being overall survival. And there is an ongoing phase 1b study of combining this agent with, again, a tremelimumab, a CTLA-4 antibody. So now moving on to slide number 16, which has a summary of the takeaway points. First, nivolumab is approved by the FDA for the treatment of squamous cell carcinoma of the lung, and showed superiority in overall survival over docetaxel in the second-line setting. Again, this issue of biomarker and is PDL1 expression the biomarker that will be used going forward. The only FDA approval that we have at this point is of nivolumab, and it's not restricted by PDL1 expression. And in fact, in the trial that led to the approval, there seems to be no correlation in squamous cell carcinoma between expression and a better outcome. And as we covered, there are other PD-1 and PDL1 antibodies in development, and they're being studied as single agents, in combinations with chemotherapy, and in combinations with other immune drugs as well. So that's the end of the standard slides. I just want to cover 2 or 3 cases from our practice here, which I think are illustrate well the spectrum of responses that one can see with these agents. So the first case is a 68-year-old female that was a current smoker at the time of the diagnosis, and she presented with a mass in her left lower leg. Biopsy showed that this was a poorly differentiated carcinoma, and the immunohistochemistry really did not settle on a subtype of non-small cell lung cancer. The patient had extensive metastatic involvement, with the primary being in her right lung. She had adrenal metastasis and brain metastasis. The brain metastasis was treated with gamma knife, and she had a performance status of 2 due to fatigue. She received 2 cycles of first-line chemotherapy, and unfortunately had absolutely no response, and was then randomized, was offered the opportunity to participate in a randomized trial between docetaxel and a PDL1 antibody. She enrolled in the study, and fortunately for her, was randomized to the PDL1 antibody. So as an example of her response, this is a CT scan from March 28, 2013, and as you can see in the arrow there, she had a right adrenal metastasis. Again, this is March of 2013, and this is October of 2013, where, as you can see, she has a very substantial response, which actually happened in all of her sites. Two interesting things about this case, besides the impressive response. One is that about a year into treatment, she developed an isolated progression in a site that was not previously involved, namely a rib metastasis, which was actually quite painful. And she received palliative radiation therapy for that and was allowed to continue in the study. Subsequently, she developed a progressive worsening rash, and actually that's reached a grade 3 with impacting her quality of life, and actually had to have treatment discontinued as a consequence of that. I think that one thing that may become clear in the future is the fact that the reported toxicity that we're seeing in the published data may actually be an underestimation of the overall toxicity, because it is certainly possible that this toxicity is time dependent, meaning that the longer that there is exposure to these agents, the rash, for example, may worsen over time. So another case is of a 55-year-old that presented with cervical lymphadenopathy, was a smoker up to the diagnosis of 20 pack a year, and had a poorly differentiated non-small cell lung cancer, which was CK7 and P63 positive and TTF1 negative. The diagnosis was on March of 2011. The patient was treated outside of our system with docetaxel, cisplatin, and radiation therapy. And on the next slide, after completion, at the time we had a trial of a vaccine as a maintenance therapy after chemoradiation, and she was on that for 6 months, but then had evidence of disease progression, had a performance status of 1, and was enrolled in a phase 1 clinical trial of an anti-PDL1 antibody, which looks like will never see the light of day, because this was a PDL1 antibody under development by Bristol Myers Squibb, and they end up favoring their PD1 antibody. So her first dose on trial was on March 20th, 2012. And if we go to the next slide, you can see that the scans just before trial enrollment on February 29, 2012, showed, as evidenced by the arrows, a right hilar adenopathy and a left adrenal metastasis. And as you can see in the scans from April 29, 2015, so 3 years later, there is substantial reduction of the metastasis in both of these sites. In fact, by design, this trial mandated that after 16 cycles of treatment, patients were, the treatment was discontinued, which happened in this patient. This has been more than a year ago. And here in Seattle, we have a bike ride, which is a fundraiser for our cancer center called Obliter Ride. And this patient has decided to ride 100 miles there are different options of lengths of ride, and she chose the longest one. So evidently, she's doing extremely well without the evidence of disease progression. And finally, the last case, moving to the next slide, slide number 23, is of a 70-year-old male. You know, the prior two patients had a significant smoking history. This one has no smoking history whatsoever. He presented with multiple pulmonary nodules, and a biopsy shows an adenocarcinoma, which was EGFR and ALK negative. He had broad molecular profiling and was found to have an amplification of TTF1 and the loss of CDK and 2A, but no actionable mutation. And he has a history of type 2 diabetes and mild chronic renal insufficiency. So next, slide 24, the patient wanted to avoid hair loss, and his renal function did not allow for the administration of pemetrexed. So he was treated with carboplatin and gemcitabine with stable disease. But then he had evidence of disease progression and was started on a phase 2 clinical trial with an anti-PDL1 antibody. So moving to the next slide, 25, you can see March of 2014, the presence of multiple pulmonary nodules. And then you can see in June of 2015, substantial improvement of all the lesions shown. This patient also developed a grade 3 rash, which required treatment discontinuation. And in his case, the disease has not shown signs of activity, and now approximately 6 months from the discontinuation of the anti-PDL1 antibody. So I think that concludes the presentation. I'm glad to answer any questions that you may have, and I think we have a little bit of time for that. So thank you.
Thank you, Dr. Martins, for that excellent presentation. And we do have several questions. The first question is in regards to guidelines. So as the number of immunotherapy options increases, will there be guidelines to identify considerations that need to be made when making treatment choices?
Yeah, I think that's obviously an excellent and very difficult question. You know, as I signaled during my talk, you know, one can make very strong arguments where targeting PDL1 would be advantageous over targeting PD1, and you can make the exact same strong arguments the other way around. You know, with the data that has been presented and published, it is hard to conclude if there will be a superiority of one strategy versus the other. As well, hard to conclude if there is a significant difference in toxicity. So it is certainly conceivable that the choice of these multiple agents will come down to convenience and cost. That's certainly a possibility.
Great, thank you. We have another question regarding side effects. So in your experience, what are the major adverse events or side effects patients experience when taking immunotherapy checkpoint inhibitors? Do you notice any differences in side effects between the anti-PD1s versus the anti-PDL1s in patients taking these agents, and how do you manage them?
Oh, how do you manage them? Yeah, that's a half-hour talk by itself. So I think that these agents will certainly bring challenges in their broad use. As I said, the serious adverse events all seem to be in the 10% range, at least with the follow-up of the published data. I can tell you that in our experience, and that's an empiric observation, at least the rash seems to be time dependent. So we are actually looking at this more formally now. We publish, in fact, I think 2 or 3 groups publish within weeks of each other, the development of type 1 diabetes associated with the use of these agents. And that's something that the first patient that had type 1 diabetes in our institution was a patient of mine, and I was totally blindsided by it because we're not accustomed to see the development of type 1 diabetes in patients that are in their 60s. In fact, when I recognized the increase in glucose, my initial reaction was to put the patient on an oral hypoglycemiant, which obviously had no effect whatsoever in someone that had developed an autoimmune type 1 diabetes. So although these toxicities are rare, they can be significant, and they require expert management as well.
Thank you. Another question. This one's regarding nivolumab. So given the really good results of nivolumab in patients with advanced non-small cell lung cancer, do you see this agent being used for first-line use?
I think that the transition into first-line, well, there are studies that are looking into that in unselected populations. But I think that the main reason why these drugs have not made a very fast transition into first-line therapy is the issue of an appropriate biomarker. If we did have a very reliable biomarker that had that in patients with this biomarker we saw a 45% response rate and a median progression-free survival in first line of greater than 18 months, and I'm just coming up with random numbers. Of course, they would make a very quick transition to first line. But, you know, as I said during the talk, in the trial that led to the approval of nivolumab in squamous cell carcinoma, PDL1 expression that did not seem to predict for the benefit of the drug. And I look at 3 abstracts that were presented at ASCO this year, including the update data on the Keynote 001, which was published at the New England Journal of Medicine. And I went through each of the 3 abstracts and look at the number of responders among patients that the trials themselves considered negative. So whatever cutoff they used, there were 166 patients that were negative for PDL1. And among those 166 patients, there were 15 responders, which is a response rate of 9%. You know, evidently, the PDL1 expression is not a completely reliable biomarker because you have 9% of 166 patients that had a pretty substantial benefit from the drug. So I think that this story is still very much unfolding.
Thank you. And speaking of biomarkers, we've noticed, and this is the next question, that PD-1, PDL1 checkpoint inhibitor clinical trials are actually including PDL1 plus for patients within the clinical trials. Now, do you think, because of the fact that some of these trials are requiring PDL1 expression, do you think that that will be something that the FDA will require once these drugs are approved?
Well, you know, evidently, if there is a trial that shows that one of these agents is better than chemotherapy in first line, and by design, only patients that had PD-L1 expression were included, then evidently the FDA approval will be restricted to the population of the trial, or at least that's what one would assume.
Great. I think we have time for one more question, and this question is regarding combinations. So, and you mentioned this a little bit when you talked about pembrolizumab plus ipilimumab. So currently, nivolumab is indicated as monotherapy to treat patients with squamous non-small cell lung cancer. It may be possible that combination of nivolumab with other agents, maybe such as another checkpoint inhibitor like ipilimumab or even a targeted agent, may provide synergistic benefits. What are your thoughts on using these therapies in combinations?
Well, I think that I'm going to give a very broad answer. We involved in the clinical development of these agents are going to be busy for a very long time doing clinical trials, exploring these strategies. I mean, the number of combinations that one can think of is enormous, not only with the agents that are already available, but also with a number of immune agents that are under development, and perhaps even cellular immunotherapy in combination with these agents as well. So, and that's one area that we are very interested. I think that that's the best answer I can give. You know, this is going to unfold over the next few years.
All right. Thank you so much, Dr. Martins, for a really engaging presentation. And thank you to our audience for participating. The webinar and slides will be available on our website,